I now invite Dr. Suma.
Good afternoon, everybody. I'm here to give a small talk on obstetric anesthesia, where, how, and when it can go wrong. So, greetings from Manipal Hospital. Obstetric anesthesia, as we all know, is a subspecialty of anesthesia where we deal with patients during the peripartum period, and we also come in contact. Okay. So, I repeat, obstetric anesthesia is a subspecialty of anesthesia where we deal with patients during the peripartum period, not only the peripartum, also during labor, and deal with patients who come for cesarean sections, and which also extends to the postpartum period at times. So, the whole conference, what has been going on is about obstetric critical care, and the theme, as we all know, is golden hour and golden moment. And so it is basically concentrating on high-risk pregnancies. I think you all had enough talks on all the high-risk pregnancies, so I will not deal with individual topics as such. It will be a general talk, and probably at the end, if you can have questions, I can respond to it too. So, basically we are there as a supportive team, and it is the whole goal of all this workshop and everything is for maternal safety. So, to reduce the maternal morbidity and mortality to the maximum possible extent. So, you should decide on things so that you don't go wrong, take the right decisions at the right time, and bring down the morbidity and mortality to the highest possible extent. Of course, we all know we give more preference to maternal safety when it comes to a question of two lives between the mother and the fetus. Normally, we give more importance to the mother's safety. So, some basic things I think I will touch upon as an anesthesiologist point of view, talking to you all. So, the general, we all know that not all high-risk patients need to go for a cesarean section. That mind concept should go that whoever is a high risk has to go for a section. No, it is not that. Patients can be taken up for labor. The only concern of a normal labor is the maternal stress response that can affect the maternal hemodynamics, and that stress response can alter the maternal physiology and can lead her into further complications in the postpartum period. So, how best can we reduce the stress response is how we look into as an anesthesiologist. So, our role here to play is to render labor analgesia. So, labor analgesia reduces most of the maternal stress response, maintains the physiology and hemodynamics during a normal labor. So, when you plan for a normal labor, I think you can go wrong probably if you don't think of a planned induction, or not allowing the mother who has got lot of high risk factors, associated medical illness, to go in for a planned labor rather than patient coming into spontaneous labor. The only thing here for a planned induction is that we can have a one-to-one communication. The anesthesiologist can be alerted by the treating obstetrician what her problems are, so we can look into it and go accordingly. And so, if we need to involve the other specialties like an intensivist, cardiologist, or a neonatologist, or even sometimes a pulmonologist, a neurologist, or a nephrologist. So, a planned induction is much safer than opting for a normal spontaneous labor. Labor analgesia cannot be taken lightly, we always feel, because it is a technique which you do out of the theatre complex, and it should be done by an experienced anesthesiologist, particularly when you are dealing with high-risk pregnancies. Various techniques have been spoken about labor analgesia, but still I think what has tested, time tested is regional techniques. Basically, it is epidural analgesia. Other things like parenteral narcotics, Entonox are there, but I think in high-risk pregnancy, not much of this holds good. Monitoring is very important. Labor analgesia cannot be taken lightly. You must have an adequate backup always. You must have a monitor. You must have an anesthesia machine standby. You must have your drugs loaded, and that too when you're dealing with high-risk pregnancy. If the patient has got some cardiac lesions, you must have your drugs like your vasopressors, vasodilators may be required if the patient has PIH, and it has to be ready. You must have an anesthesia machine standby. A good team backup is required. When I talk about patients, regional techniques like epidural, there is a role for even a combined spinal epidural, particularly in cardiac patients where they have severe cardiac stenotic lesions, where you have to go slow on your drugs, the volume of drug and your concentration of your drugs. So in those cases, you can think of a combined spinal epidural where you can give an intrathecal dose of a small dose of narcotic like fentanyl, around 10 to 25 micrograms, which takes away the pain. So once the pain is taken away, probably the stress response, the maternal stress response comes down to a very large extent. So once that is done, you can top up with an epidural dose with even half the concentration with a small dose of narcotic. So you can maintain the hemodynamics and have the mother passing through a safe confinement. Particularly in cardiac patients, there is something called a vaginal cardiac delivery where you can use an outlet forceps or a vacuum so that you avoid the maternal pushing. Maternal pushing is basically a Valsalva maneuver, and this Valsalva maneuver can increase the intrathoracic pressures, can have an effect on the cardiac output. So if you have an increased intrathoracic pressure, it can precipitate even a cardiac failure in terribly stenotic cardiac lesions. A word about drugs, what we use. Use whatever drugs you are using during labor with caution. Particularly with a small note on what routine drugs, what we use, that is oxytocin. Oxytocin can be given as a small, as a avoid bolus doses at any cost, and you can give pitocin as a slow continuous infusion rather than bolus, particularly in cardiac patients. Misoprostol is safe in cardiac patients, but you use it with caution in patients who have any respiratory issues. Methergine is almost contraindicated, and it has to be totally avoided in patients with severe PIH or other cardiac issues. So once you, as I said, not all patients need to go for a cesarean section, but most of them, you have to have always in your mind that this patient is likely to go for a cesarean section at any time. So we have to be prepared and decide what has to be done accordingly. It depends on, decisions have to be made at the right moment. Any delay in decisions can also affect the maternal health, even the fetal health also at any time. So if the patient is coming for a cesarean section, it can be either two things. It can be an emergency section or an elective plan section. Elective plan section is always, we are always prepared for, we have a good backup, and I think we are more prepared for it. But there are situations where you have to be prepared for a real emergency situation where you have no time and there is so much of distress that the mother has to be taken in for a cesarean section. So when you go for a cesarean section, we have mainly two options left to us options of anesthetic techniques. Basically, it has to be either a regional anesthesia or a general anesthesia. I think a word about general anesthesia, it is a myth, I would say, that general anesthesia is unsafe. It is always, general anesthesia is very safe, and probably I would really say that it is the most safe technique when it is performed rightly by a experienced anesthesiologist. So I think we have to take off the mind that general anesthesia is unsafe in a pregnant patient. Of course, regional anesthesia is much better when you consider the safety of the mother and fetus, but of course when it is conducted, general anesthesia is conducted properly, I think it is very safe. Regional anesthesia, as we talk about regional anesthesia, it could be either a spinal, it could be an epidural or a combined spinal epidural. Again, the choice of your anesthetic technique depends on the patient's condition, your emergent situation, and various other factors which you take: patient's consent, coagulation disorders, local infection, and patients probably with the HELP syndrome. Then all these patients, you have to think of whether the patient is right enough to go for a regional technique, especially when you have a platelet count dropping over a period of time. Though you may, if the patient is having a platelet count dropping very frequently, in the sense the previous night it is 1 lakh, next day morning you see 70,000, and you feel the platelet count is dropping, then probably you think of not going for an epidural. And actually we don't go for an epidural technique if the platelet count is below 1 lakh, above 70,000, okay, fair enough, some textbooks say. But if you find there is a rapid decline in the levels and you are, I mean, if there is a clinical scenario where the patient is going for a HELP syndrome, probably you can go for a general anesthetic technique rather than spinal. As regards with everything, a meticulous and systemic preparation of the theater is very important. As a team leader, as an experienced anesthesiologist with a good team leader and with good support system, things can go well. And with the patient, with all importance given to the mother and the fetus. All monitors have to be available. Basic monitoring like an ECG, non-invasive blood pressure, pulse oximeter is essential. In cases with severe cardiomyopathy or patients with severe PIH who is on multiple drugs and various other severe cardiac conditions, patients come with severe pulmonary artery hypertension, that too with all these latest, I mean, we find that patients are going through all these procedures with much safety because of better monitoring systems which we have. We go in for invasive monitoring like invasive arterial blood pressure, continuous CVP monitoring. Some patients might require even a pulmonary artery catheters or even trans-echocardiography in severe cardiac conditions. We often come across severe cardiomyopathies who present to us in late pregnancies who are not previously diagnosed. So essential monitoring is very important, and eternal vigilance is a key word of anesthesia. We never miss upon it, and continuous monitoring is really required. Patients who are unstable and you feel that they are requiring supports in cardiac patients or severe PIH where they are requiring multiple drugs, it's safe enough not to extubate the patient and shift them with the tube and shift to an intensive care unit. So just to summarize, like what the main topic is when we can go wrong. So things can go wrong when we do not work as a team. Effective communication about the patient condition with good planning helps us, and it can avoid lot of trouble and you can make things go right. This involves a multidisciplinary unit like talking with the obstetricians, anesthesiologists, intensivists, cardiologists, neonatologists, and other specialties like nephrologists, neurologists, or pulmonologists, or whatever it is. An experienced anesthesiologist with a good team backup always makes things go right. A very important thing what we have to take it is, do not attempt high-risk obstetrics if you do not have a good intensive care backup. We are always very thankful that we have a good intensive care unit, so we can handle most of the obstetric emergencies in quite a successful manner. It is wrong to consider that high-risk obstetrics need an operative delivery. Judicious use of labor analgesia can mitigate the maternal stress response. Options of anesthesia include regional techniques, general anesthesia. It is wrong to consider that general anesthesia is not safe. Regional techniques, I forgot to mention, there are some, there are conditions where people go in for local blocks, like TAP blocks and local infiltration blocks. But I think with good monitoring and with good backup of ICU and all that, it's safer to go for general anesthesia or other regional techniques rather than going for local infiltration. Of late, people are talking about erector spinae block bilateral, which helps for postoperative analgesia also. Choose the technique, whatever you are comfortable with, keeping in mind the maternal safety and what the clinical condition is. An honest approach to the situation is very important. The severity of the situation should be explained to the patient family. A high-risk consent has to be taken, and you have to explain to the family this patient will require an intensive care unit in treatment in the post-operative period and involved whatever medical specialties, whatever the patient requires for pre-operative or preparation or in the post-operative care also. And do not delay surgeries if the patient's life is in real danger. I think we had a patient who had postpartum severe, patient had a section, and 2 days later she complained of severe pain and she just collapsed. She was shifted to the ICU. She went in kind of a shock and postpartum, suspected probably amniotic fluid embolism. Her INR was 7 and we had to rush into the theater with SDP and FFP and all that. We had to open her up and she had a hysterectomy at that period of time, shifted with the tube. She went into AKI and she had to be dialyzed. She was on a ventilator probably for 10 days. She came out of it, she was on dialysis. That day INR was 7. We had no choice. I think Sunil Karath will remember the patient. So at INR of 7, we had to do the patient. We had no other choice. But if an honest approach, tell the patient that these are the things, life is in danger, you have to go ahead. If they give a consent, I think whatever be the risk, we have to take a decision and go ahead. And that patient with that INR of 7, we still remember she went home and her kidney functions also got back to normal. So I think things can go wrong when we do not work as a team with experienced professionals. Thank you.